Well, hello everyone. I really appreciate the opportunity to present to you today. I'm going to take my mask off. Association of Program-Specific Variation in Bariatric Surgery Volume for Medicaid Patients and Access to Care, A Tale of Inequality. Some of the authors do receive some salary support from Blue Cross Blue Shield for participation in the Michigan Bariatric Surgery Collaborative, but beyond that, there are no disclosures. It is predicted that severe obesity, so defined by a BMI of greater than 40, is likely to become the most common body mass index category among low-income adults and minorities even by 2030. We all know in this room that bariatric surgery is a very effective treatment for obesity and obesity-related complications. I don't have to tell you that. And despite differences in socioeconomic status and demographics, patients with Medicaid demonstrate significant weight loss and improved obesity-related complications. However, the vast majority of patients undergoing bariatric surgery hold private insurance. The number of patients undergoing bariatric surgery with Medicaid insurance is definitely increasing. We have seen that throughout the years. That's due to many efforts like the Affordable Care Act's Medicaid expansion. However, a gap in disparities does persist. So our question was, do patients with Medicaid insurance experience limited access to bariatric surgery as a result of program-specific variation in volume and proportion of cases by insurance type? Data was collected from the Michigan Bariatric Surgery Collaborative, which is a statewide registry for collaborative quality improvement. It includes 43 programs across Michigan. 97,207 bariatric cases between 2006 and 2020 were evaluated, and we included patient characteristics, payer type, comorbid conditions, postoperative complications, and resource utilization. Bariatric surgery programs were stratified into quartiles based upon the percentage of cases that they performed on Medicaid beneficiaries, and I'm going to show you that in the following slide. Program-specific characteristics, as well as baseline patient characteristics, risk-adjusted 30-day adverse events, and wait times, meaning time from first office visit to actual operation, were compared between the top and the bottom quartiles. Here you can see these quartiles that we made. Now we're looking at a high volume, meaning high volume of Medicaid cases versus a low volume of Medicaid cases. So in the green, the program that performed the highest percentage was 20%, and then the rest of their cases were non-Medicaid cases. And you can see from the green to the yellow, there is a significant difference in that. Now looking at the programs again, the top quartile compared to the bottom quartile, there were 32,447 cases in the bottom quartile. That means all cases, not Medicaid and non-Medicaid, compared to the top quartile, which performed 18,851 cases. The mean percent of Medicaid cases, per site was 0.5% for the bottom quartile versus 13.5% for the top quartile. Now, as far as the actual hospital, its location, what type of hospital, and the type of procedures actually performed, those weren't statistically significantly different. But what I do think is important to note is the bottom here that says the median number of days between initial clinic visit to surgery. So it's significantly greater for that top quartile, again, that group that has the most Medicaid cases. And the median number of days was 200 versus 122 for that the bottom quartile. Looking at patient characteristics, we didn't see a difference in the top and bottom quartiles according to gender, but we definitely saw a greater number of Black patients in that top quartile. And then, as we would all expect, with Medicaid insurance, we have more patients with lower income, less employment, and less education. And then at the bottom here, it does show you that there's a statistically significant difference in BMI and age. However, if you actually look at the numbers, that's not clinically relevant. That's not a clinically relevant difference. Patient comorbidities, and this is important. So the top quartile, pretty much across the board has more comorbidities. So diabetes, that's really important. We want to know what patients have metabolic disease. Hypertension, hyperlipidemia, sleep apnea, you can see the rest. With the exception of smoking status, that was not different. As far as complications, again, across the board, we're seeing a greater percentage of complications among that top quartile. So any complication, medical complications, surgical complications, really with the exception of leak or perforation. Now this is important as well, length of stay, ED visits, readmissions, reoperations, and basically overall resource utilization was greater for that high Medicaid group, that top quartile. We demonstrated that programs vary considerably in the volume and proportion of cases performed for Medicaid beneficiaries. Programs that performed the highest proportion of Medicaid cases also performed a lower overall volume of cases. High-volume Medicaid programs care for patients with greater disease severity and demonstrate more postoperative complications and resource utilization. And time to surgery is greater for patients at high-volume Medicaid programs. In conclusion, despite an increasing number of Medicaid cases, which we have seen throughout the years, there is an inequitable distribution of care. There are multiple potential disincentives for programs to care for patients with a lower socioeconomic status. We're all very aware of outcomes. It's very important as a surgeon into a hospital, and we know that these patients have a greater burden of disease and more complications. So insurance criteria standardization for bariatric surgery and program-specific incentives to expand the care for Medicaid patients may improve the gap in disparities. Thank you, and I'll take any questions.